Have you ever been diagnosed with trigger finger even though you don't own a firearm? We're going to learn about trigger finger.
Here we go. Welcome to Talk with Docs. I'm Dr. Brad Weeding.
And I'm Dr. Paul Zalzal, and we have
Dr. Noor Alalabi.
He is a plastic surgeon who is going to talk about trigger finger, and we at Talking with Docs do not believe in firearms.
Nope.
Nobody should own them. That's our view here, but we live in Canada. But trigger finger has nothing to do with a gun. It has to do with your finger.
And before we start, if you have experience with trigger finger, if you have this, if you've had it, if it's cured, not cured, you know someone that has it, leave a comment. It helps everybody when they read the comments. So let's start at the beginning.
Sure.
What is trigger finger?
So the technical term for trigger finger
Okay.
is actually flexor stenosing tenosynovitis.
Yeah, that's too hard to say.
So trigger finger,
You have to get that out of the way.
basically.
Okay.
So what is trigger finger? Essentially what happens is, with time, as we use our hands, you start to develop inflammation around your tendons.
Okay.
All right, so now our tendon, our flexor tendon in particular, goes through a little sheath. So it's essentially like a tunnel that it travels in. And over time, as we develop this inflammation, that inflammation now makes the tunnel, the tendon bigger and wider. And so as it tries to go through this sheath or tunnel, it gets stuck.
Okay.
All right, so people go ahead, they try to make a fist, and then while they make a fist, their finger gets stuck and they just cannot open it. Right. Sometimes they need the other hand to manually open it.
And that's why it's called trigger finger, because it's like a trigger that just clicks in and out.
That's right.
Okay. So who gets this? It sounds like a disease of age, kind of.
Basically, yeah. So I mean, this is very, very, very common. Diabetics do have a higher chance of getting this, mainly again just because of the inflammation. But essentially, it is people who just use their hands, which is essentially anyone.
Okay. Men versus women, is it more common in either?
I don't think
Slightly more common in women,
slightly more
maybe?
common in women, but
Okay.
fairly equal, I would say.
Okay, but it's a fairly common disorder. I'm sure someone who's typing now just had trouble typing the E or the F or something.
I
because
read
they
the
have trigger
prevalence is
finger.
in the 2 to 3% range.
Yeah.
So two out of every 100 people in the world kind of
Yeah.
have this
Yeah.
at some point in their life.
Yeah, so that means at least one of you who's watching this video has it.
Okay, so someone looks at their finger, they realize they've heard about this, they're not very sure, so they go to their family doctor. What's their family doctor going to do to kind of get the ball rolling?
Yeah, so sometimes, they'll order x-rays, ultrasounds. Again, you don't really need any imaging for this type of condition. So no need for ultrasounds, no need for x-rays, no need for MRIs. This is, again, a clinical diagnosis.
Okay, so good history, good physical exam.
That's right. Once you basically have pain, essentially right at the base of the fingers, right in here. So this is an area called the A1 pulley. That's where that tunnel starts. And essentially, when you push on that area, if it hurts, if there's a click, if there's a trigger, you've got a trigger finger.
Okay.
And it's as easy as that to
Nice
diagnose.
clinical diagnosis.
Yeah.
So you've got the history of some fingers getting stuck. You go see your doctor who does that simple test, clinical diagnosis, no other investigations necessary. Can we talk about treatment yet?
What I was going to say is,
Yeah.
do you have to get it treated? Or if someone said, listen, I don't want any kind of treatment, I don't like going to the doctor, I can live with the pain and I don't care if I click it back and forth, is there any reason to not get it treated?
So yes, you can leave it. The only thing that can happen over time is if it actually does trigger. What happens is that tendon over time can actually fray a little bit.
Right.
And what actually happens is over time, you can develop a little bit of a bend at this middle joint called the PIP joint. And so people will sometimes come who've had a trigger finger for a very long time, and they've got a little bit of a bent finger, and they'll say, well, why is this here? Because you've let your trigger finger too long.
Got it.
Yeah. Or if your middle finger is stuck in the extended position, that may be an indication too, Brad, whether you like it or not.
Correct.
Okay.
Although I will say trigger finger, usually it's stuck
flexed.
in flexion, not extension.
That's right.
Fair enough. Okay. so
That didn't work. That didn't work for the joke.
Okay. So
Sorry, Paul.
Unless all your other fingers are stuck flexed.
Hey,
Fair.
that works.
Fair. So you're at the family doctor. They've confirmed the diagnosis from the history and physical examination. Now you're like, okay, what are my treatment options? Let's start right from non-op all the way to potentially operative.
Yeah, so splinting can be done. Sometimes the therapist can make you an extension splint to wear because of the pain again that happens with flexing.
Right.
The only thing with that again is you may start to get stiff because
Right.
you're not moving your finger as much anymore. Some physiotherapy can help with this.
Does that reduce the trigger incidence of triggering, or just prevents the contraction?
It honestly can.
Oh, okay.
However, we don't really use it as a treatment tool per se.
Right.
Because again, sometimes it's just, inflammation goes up and down.
Right. So the thought is if you can quiet it down, maybe it's going to
That's
make
right.
more room underneath
That's
the bridge
right.
kind
That's
of
right.
thing,
That's right.
through the tunnel.
That's right.
Okay.
But really, I mean, ultimately, you're looking at the next step is being cortisone injections.
Okay.
Right. So, cortisone injections, what's going to happen is some of that inflammation is going to lessen to a certain degree. Think about it essentially as in physics, right? You've got a tunnel
Yeah.
and you've got something going through it. Either you're going to have to decrease the stuff that's going through the tunnel,
Make the tunnel
or you're going to
bigger.
have to make the tunnel bigger. And so it's very simple. The cortisone injection, all you're doing is you're decreasing some of the inflammation,
Yeah.
and so it may actually resolve some of the triggering.
So cortisone is just a very powerful anti-inflammatory drug. That's why we have NSAIDs, non-steroidal anti-inflammatories, which is like aspirin, but steroids are powerful anti-inflammatories and widely used for that purpose. So directly injecting it takes down the inflammation in the tendon.
And so so it's exactly injected right directly into the tendon.
It is injected into the, not the tendon, into the tendon sheath.
There we go.
In
Yeah.
the sheath.
Yes.
So you want to inject it around the tendon. And the idea, again, that can be done in the palm, that can be done actually here. As long as it's in the sheath,
Yeah.
that steroid is going to go everywhere.
And now the average user is going to say, well, how are you going to know if you're in the sheath or the tendon? Is it all about resistance rather than using like a fancy ultrasound or something like that to do the injection?
So honestly, this is preference, I would say, surgeon preference or physician preference. I personally actually inject it right in here.
Okay.
What I do is I just go through the tendon all the way down to almost to the bone.
Right.
Because now I'm at the back of the sheath and
Right.
I'm 100% in the sheath.
You know that you're not injecting in the tendon.
Correct.
Okay.
Absolutely.
Through the tendon with the needle.
Exactly. You just go all the way through.
And no damage to the tendon
no
by
damage
passing
to
a small needle through it.
Absolutely not.
Okay.
You can go in the palm and you can kind of do it by feel. So get the patient to sort of move the finger and you make sure you're not actually in the tendon.
Because if it was in the tendon, you would feel the needle moving, you'd feel
Correct.
the tug, and the patient would feel it as
Exactly.
well.
Exactly.
Okay.
Interestingly, there was actually a study which showed that if you injected the steroid not even in the sheath, and it was just around
In the
the sheath,
vicinity.
in the vicinity, that actually still improved. So
It's gonna
at the end of
diffuse around
day-
the whole area.
Yeah. At the end of the day, it probably, it's not super critical,
Yeah.
but we
Yeah.
certainly do encourage that it is injected.
Has to be near it, just not in the tendon.
That's right.
Yeah.
Okay.
So it should be horseshoes, hand grenades, and cortisone injections.
There you go. There you go. Okay, so you've done this, patient leaves. Do you tell them to rest for a little bit afterwards, or they can just go back to their normal activities right away?
Yeah, so usually when we're injecting cortisone, it can have a bit of a sort of a pain,
A flare
full,
kind of response.
Yeah, a little bit for a couple of days. So we try to tell them, not to work out for a couple of days, not to do anything super heavy. Usually takes about a week for it to start working.
Okay.
And sometimes the family doctor is doing it. So, you'll get a lot of patients that come to you, they've either seen their family doctor or a sports medicine doctor, and they've already been injected, a rheumatologist, So typically, we like to inject, or personally, I like to inject the trigger finger once.
Right.
And if that doesn't work, then we go on to surgery. But before we talk about surgery, let's talk about how good is the cortisone injection.
Sure, and I was going to say, how do we measure? Are we measuring it reduced pain or reduced triggering, or
symptoms.
both?
Both.
Okay.
Both. Some patients will come in and they'll say, yeah, I've got a little bit of a click, but it doesn't actually fully trigger.
Got it.
Other patients come in and they need to manually open that finger.
Yep.
And so really what we're looking at is decreasing of the triggering or the clicking as well as the pain.
Okay.
And this varies.
It's
right? So-
clinically determined, right? Just how the patient's doing.
Absolutely. It varies. Sometimes it gets rid of it completely. Sometimes it gets rid of it for a year, 6 months, 4 months, 2
Yep.
months. It very much varies, and we cannot predict which patient is it going to work in and which patient is it not going to work in.
Okay. Generally successful, would you say?
Generally successful in the sense that it will have a benefit,
Right.
but we don't know how long that benefit is
How
going to
much
last
and for how long.
Exactly.
And you just give that one try, one strike. Not much of a baseball
So a
player.
lot of surgeons or physicians will do more than once. We have good data to show us that the first injection is actually the best injection, and then after that,
Diminishing returns.
It diminishes, exactly.
Okay, gotcha.
Okay, so now you've had your one injection, worked for a bit. I'm right back. Now it's worse. I'm getting stuck. I'm manually manipulating. I can't live this way because I got a job. I need my hands open.
That's right.
What do we talk about as far as the next solution?
Yeah, so the next basically option is surgery.
Okay.
And with surgery, very straightforward. Essentially what we do under local anesthetic, freeze the finger, make a small little cut right in the palm.
Like how small are we talking?
We're talking a centimeter, centimeter and a half
Yep.
of an incision. And then you go down and we just open up that sheath, that tunnel. We just
Okay.
completely split it open, and it's not going to have any detrimental effect on your tendon function or on any of your strength of the hand or anything like that.
Okay.
All right, so it is a very safe procedure. We open that sheath up, and now the tendon can just come in and out of the tunnel fairly smoothly.
Ironically named the A1 pulley since it's not really that important.
That's right.
Usually A1 makes it.
What I would say is that what do we think the role of that pulley is then? If we can remove it
Yeah, good question.
and it's still okay, is it like the appendix? Is it vestigial? And do we think maybe we kind of outgrew the need for it? Or?
Yeah, so very good question. I get that a lot, actually.
Okay.
So people will say, you know what, you're going to cut this. What's
I
going to
need
happen
it,
to my
yeah.
hand? Exactly. So we actually have 5 of these A pulleys. There's A1, 2, 3, 4, 5. And so if you go ahead and cut all of them, yes, you're going to have some changes in the function of your hand and of your tendon. But this one particular A1 pulley, you cut it, nothing will happen.
That's awesome.
Okay, good to know.
Post-operatively, for the incision people, are they taking a little more time off work? They have to take it a little more easier than the injection people?
Yeah, absolutely. So, I mean, it takes about 2 weeks roughly for the incision to heal.
Yep.
Usually you'll get some stiffness, you'll get some swelling. So for the first 6 to 8 weeks, you're going to find that your strength is probably not, all there. Grip strength is going to decrease. You're just even making a full fist, you're going to notice that your finger's a little bit bent and it's going to be a bit tough to do that.
Does it ever recur after you treat it surgically?
It can.
Okay.
I will say that if you've done a full release, it's fairly uncommon for it to happen, but yes, it can recur.
All right, that's trigger finger.
Now you know, if you had one, now you know how to get rid of it.
Probably what Lone Ranger's horse was named after.
Maybe. If you like this video, please like it, subscribe to our channel.
And remember, you are in charge of your own health.
And thanks to Dr. Alalabi for joining us again.
My pleasure. Thank you guys.
We'll see you next time.